Should we be checking a gag reflex in altered patients and using the presence or absence of that gag reflex to determine whether we should be intubating that patient for airway protection? The classic teaching is that if the patient doesn't have a gag reflex, they can't protect their airway, they're at risk for vomiting, aspirating, developing an aspiration pneumonia, and so we should intubate those patients to protect their airway. But this is actually a massive oversimplification of the gag reflex, which involves multiple neural pathways and multiple cranial nerves. The absence of a gag reflex doesn't mean that that patient is at a higher risk for aspiration, and in fact there's data that says exactly the opposite. We know that the gag reflex can be absent in up to 40% of patients at baseline, and those patients aren't walking around as aspiration risks. Even if it was a good idea to intubate patients without a gag reflex, we first got to check them for that gag. Now we have an altered patient where we're shoving something in the back of their throat, they're gonna gag, it increases their chance for vomiting and for aspirating that vomit. Essentially, we are causing that aspiration event, and now the airway is gonna be filled with vomit when we are trying to manage it. We've really got to put this dogmatic teaching to bed. We shouldn't be checking gag reflexes in altered patients, and we shouldn't be using that information as a decision point to intubate or not intubate for airway protection.